Right. So these medications are lipid lowering agents. If you had to guess, what are we talking about? That's true, cholesterol. So all of this is going to be concerning cholesterol medications. Okay. So for everything that we are going to talk about, if we are lowering lipids, what are things that you think that we need to monitor? Okay, lipids, very good. So we're monitoring cholesterol levels, we are monitoring triglycerides, and we know that there are external influences like our diet, our exercise that we also will expect for patients to modify, okay? Things that they are able to modify. So all of that is going to apply for everything that we are discussing. All right. We talked about in pathometabolic syndrome, which is just a accumulation of these various states: high blood pressure, inflammation, obesity, elevated lipids that put people at risk for developing diabetes, coronary artery disease, high cholesterol, all those things. This chart is on page 828. So if there are any of these things that we can modify or control, that is going to play a role in us managing conditions that could arise from elevated cholesterol levels. Okay. This is just additional breakdown of that. Um, so things that we cannot modify that put people at risk for atherosclerosis and cardiovascular disease are genetics. We can't help what was passed on to us. We hopefully will age, but that does increase our risk. Also, risk increases for women once they hit menopause because of hormonal changes. And then men have a higher incidence earlier in life, but that risk kind of evens out once women hit menopause. And that atherosclerosis is the buildup in of plaque in their coronary arteries, which leads to damage and inflammation, which progressively leads to damage to their arteries and restricted blood flow. Okay, so ultimately, cardiac output and workload can be impacted, and they are going to be at risk for peripheral artery disease and ischemic stroke. Okay, which is why it is important for us to treat that before they develop those things. Okay, so I have a note here to look at the boxes on 828 and 829. Um, Things that we can modify: they need to stop smoking, they need to be active, they can stop the intake of those unhealthy type fats or high salt, and then control their stress levels. We can treat blood pressure, their diabetes, cholesterol, help them lose weight, as well as treat gout because uric acid can also damage their vessels. So any medication that we are going to discuss would be in conjunction with teaching them to modify those things. Okay. I do have a note that on page 830, table 47.2 goes over some suggested modifications. Those are going to be important. This is a pharmacology class, so the things that I'm going to be talking to you mostly about are medications, right? But you do need to understand that you're not solely teaching somebody about a medication, right? In addition to me giving you this medicine, you need to know how to manage these conditions. This will make more sense and be more of a holistic type approach once you get in adult health and you're learning all of those other treatment recommendations as far as modifying that. But I do want y'all to recognize that when you're thinking about a medication, you also have to think about potential things that could be contraindicated with it or things that need to supplement their treatment. Okay. If I am, I'm trying to think, arthritis, if I have arthritis and you're giving me medication, because what am I going to have if I have arthritis? Probably. pain. I'm going to hurt, right? And so if I am receiving a medication for this, I went to the doctor obviously because I was in pain. But if I tell you that I run every day and as I run, it makes me hurt, if I continue to run, is this pain going to go away just because you gave me this medication? No, I have to have conversations about that's part of supporting that. Okay. So I just want to make that designation. All right, this picture that is on the next slide that kind of goes over what this is on page 831. So we ingest fats, our liver puts that into lipoproteins. Those are transported, the lipoproteins transport the fat through our bloodstream, and then our cells use those and either use them for energy or store excess. Okay, so excess would be when there is a problem. This is a further, more elaborate discussion of how all of those things take place. Okay, understanding that will help in how these different medications are going to work and how they're going to lower our cholesterol. All right, so the lipoproteins include HDLs, which we want to be high. Okay, that is considered good cholesterol. Those transport lipids to our liver for removal. LDLs are our bad cholesterol. IDLs and VLDLs, those are going to transport triglycerides. And then those chylomicrons, those are in the small intestines for dietary fats. Okay. So cholesterol, we've said what it did. It also serves as a base for hormones like estrogen and testosterone. And then as we take in more saturated fat, if we have a diet high in saturated fats, it increases the potential for our liver to be overwhelmed, for those to be stored, and for plaque accumulation. Okay, so we don't want that to happen. So things that can contribute to hyperlipidemia or elevated cholesterol in our blood are excessive intake, if they have some sort of just genetic predisposition to that, or it could be caused by other conditions. I do have a note that the treatment guidelines for hyperlipidemia are on page 832 and 833. So the first thing that we want to teach people to do is take in less, right? Even if diet isn't the problem, if they have a genetic predisposition, taking in more is still going to make them have more. We also want to make sure that they are getting up and moving. They don't have a sedentary lifestyle, and then we'll start them on medication if those things don't do the trick. If it is genetic related and it's not due to their diet, then medication is going to be necessary. All right, first question. LDLs or low density lipoproteins are known as the good cholesterol. That's false. And the way that I remember these, and if I'm honest with you, I get confused and have to remind myself of this. It does help me to remember, like the L, I want those to be low, and the H, I want those to be high. Okay, so if that can maybe help you remember. So those are considered the bad cholesterol. All right, so the different types of drugs that we are going to talk about are going to lower our cholesterol and other lipids. I'm going to go over these uniquely or individually, but do understand that sometimes people are on multiple, and I will try to point out which ones shouldn't be combined, okay? Because that is a consideration. The table for these is on page 835 to 838. So we have bile acid sequestrants, which bind bile acid in the intestine, help us excrete that, and prevent it from being reabsorbed. The HMG CoA reductase inhibitors, the other name for that is statin. Those are typically the first line medications unless there's some sort of contraindication. Those block the synthesis of cholesterol. We have cholesterol absorption inhibitors, which prevent intake of absorption of dietary cholesterol. And then the PCSK9 inhibitors, those are, what is the word for these? Like immune modulator type drugs, okay? Those are given less common, but those just help the liver be able to use LDLs better, to get rid of them. And then fibrates and niacin. And again, we'll talk about these individually. This is just another thing that goes over which drugs fall into this. I thought this might be helpful for y'all to look at. And again, just something that can help break down what drugs fall into which categories. Here is the chart in your book about things across a lifespan, and I have the next slide is things that I want to discuss from that, but you are welcome to look at it. So for pediatrics, these cholesterol or lipid lowering agents aren't typically used because that typically isn't a problem. A lot of times these things are diet related. So if they are using this, most of the time this is because they have some genetic predisposition, and often they are on fibrates or statins. And then adults, we really are, for one, trying to treat this, but also trying to prevent complications that can come from atherosclerosis or from that plaque buildup. So the statins or the HMG CoA reductase inhibitors are the first drug of choice. And then if that remains high, a lot of times that is combined with Zetia or ezetimibe, if those are still high. And then those immune modulators can be used, but I would say that those are used less often. We're not even really going to get into talking about those. One of the biggest risks, and I would say as a whole, unless I specifically say otherwise, muscle breakdown is something that can occur from taking lipid lowering agents, specifically statins. That's a huge concern with that. So as those muscles start to break down, something has to happen with the accumulation of that in our body, and our kidneys can be affected. And so rhabdomyolysis is that profuse breakdown of muscle tissue, which can lead to kidney damage. So that is a big side effect and risk associated with these medications, and that is increased in the elderly just because they already have slower processes. So for all of these, we're going to monitor liver enzymes. We're going to monitor if they have that muscle pain. We will monitor their cholesterol levels, their triglyceride, and then if they have muscle pain or if we suspect that, do y'all remember what lab we do to check for muscle breakdown? Creatine kinase, do you remember that? CK. So we will measure those to determine the level of if their muscles are breaking down and have been impacted. Most of these drugs are contraindicated in pregnancy, but bile acid sequestrants can be used if they absolutely have to be. And then this picture just shows where those medications are working in relation to how cholesterol is processed and excreted and stored in our body. And that's on page 835. All right, so the first thing that we're going to talk about is bile acid sequestrin. So these bind bile acid in our small intestine, which prevent it from being absorbed, and then it is eliminated through feces, okay? And so because of that, because it's not absorbed, then our cholesterol levels are lower. However, these can increase triglyceride levels, so it would be important to monitor both of those as treatment is underway. These medications include cholecystiramine, cholestyramine, and colesevelam. So that chole can kind of clue you in that those are for cholesterol. Um, and that's really it with that. So because they are excreted in the feces, what do you think it is very important for me to be able to do? Get them out of there, right? So constipation is a huge concern with these medications. So what would I do to prevent them from being constipated to allow them to excrete these? Increase fiber, increase fluids, activity, and just teaching them that that is part of this, right? You need to make sure that you are taking in plenty of fluid, you're taking in fiber, and you should be having a bowel movement. If you're not, that's a problem and you need to report that. Um, these do come in different forms, but just as a general statement, specifically cholecystiramine is a powder, and so it needs to be mixed with a full glass of water, and then they also need to increase their fluid intake, okay? And usually they take this like once or twice a day, but it can be taken up to 6 times a day. So just depending on cholesterol levels and if they're using other things. So this can be used for if people have high cholesterol, high LDLs. It can be used in conjunction with diet and exercise. And if somebody has a partial biliary obstruction, it also can be used to treat pruritus associated with that. Yes, ma'am. I think so. I haven't. Well, just in general, when you're mixing medications with things, carbonated meds are harder for it to mix with. I don't know if specifically if there's like a reason that it's interacting with the carbonation, but I think more than anything, it just doesn't mix very well. Um, and I have a note on whatever drug that is. I have a note. It very well could be this. If you want me to tell you the truth, I've never given any of these medications. That doesn't mean that they're not given all the time. That's just my experience. Statins, I've given 800 million times. That is more commonly what I personally have administered. Um, so if somebody is allergic or they have a complete biliary obstruction, this would be contraindicated because it does require the bile in order for it to work. Okay. Um, or if they have constipation or some sort of impaired intestinal function, this is considered the safest choice for pregnancy. So we want to make sure we teach them, take with a full glass of water, increase their fluid and fiber intake. Some of the complications from this are GI related, so they can have hemorrhoids, fecal impaction, constipation, nausea. One of the bigger things is an increased bleeding time. So if somebody is already at risk for bleeding or they're on some sort of anticoagulant, we either need to try something different or know that that's going to be an increased risk. Um, and then they have a potential for vitamin deficiencies, and then these also carry the risk for the muscle aches and pains. Okay, so these can decrease the absorption of fat soluble vitamins like A, D, E, and K. So the interruption with vitamin K contributes to it increasing bleeding time because vitamin K plays a role in clotting. Okay. It can also decrease or delay the absorption of thiazide diuretics, digoxin, warfarin, thyroid hormones, because it binds to the thyroid hormone. So it would need to be separated. We have to take those medications either 1 hour before or 4 to 6 hours after the bile acid sequestrants. Okay. These can reduce the effectiveness of oral contraceptives as well as corticosteroids. So they may need increased dose of corticosteroids. And if they are taking this medication and are trying not to be pregnant, they need some other sort of contraception, okay? Because it's not going to be effective. I have a note here, page 838 and 839 go over the nursing considerations for these medications. And yes, says do not combine with non-carbonated. So I will look, sorry, combine it with non-carbonated. I will look to see if there's any reason for that because I am curious now that you asked, but I really think it's more than anything just the mixing of it. And then make sure they have fluid fiber, and they may need supplemental fat soluble vitamins, okay? Especially if they're pregnant. All right, moving on. The HMG CoA reductase inhibitors, also known as statins. So the medications in this category you will see all end in statins. Pretty much how they work, what they do, nursing considerations are going to be the same, except for some of them have to be given with the evening meal because our cholesterol is synthesized in the evening. And so this makes them work better. Okay. And I have a picture that says specifically which one of those that applies to. So these decrease the lipid levels because they interfere with lipid synthesis. And so they are indicated to lower the cholesterol levels and reduce the risk for cardiovascular disease, including strokes, MIs, or peripheral vascular disease. So they decrease LDL. They can also increase HDL less effectively, more effective at decreasing the LDL. So they are given for high cholesterol and prevent coronary artery disease and then complications from that. And again, given in conjunction with modifications to diet and exercise. These do take a little while to start working, so usually they will go into effect or work most effectively within like 2 to 4 weeks. Most of them can be taken at any time of the day with or without food, but like I said, some of those specifically need to be taken in the evening. My recommendation for that, if you don't remember once you're practicing as a nurse, is if you see somebody who's taking their cholesterol medicine in the morning and you don't remember that, then just check to see if it's one of those that are supposed to be taken at night so that you can make that and advocate for that. So we don't want to give this if somebody has liver disease. If they are pregnant, we definitely don't want to give this to them, or if they have renal impairment. So it isn't necessarily affected by renal disease, but because there's that risk for rhabdomyolysis, it is going to be an increased risk if somebody has kidney issues. So we just have to make sure that we're using that cautiously. And then if they have some sort of impairment in their endocrine function, it could interfere because of it impacting corticosteroids. Okay. Most of the time, them taking these medications causes an increase in their liver enzymes. So if I'm worried about that, what labs am I looking at? Very good. AST and NALT. Okay, so that's going to tell me liver function in a lab. Now, hepatotoxicity, because it can affect their liver, is a huge concern. If I'm concerned that they have developed hepatotoxicity, what is that going to look like? Jaundice. Very good. What else? They may have ascites, itchy, they may have pruritus.
I'm thinking of mental.
That can be, so I'm not mad at you going there. People can have hepatic encephalopathy. Coming from medication is probably a stretch, but I'm not going to say no. Probably depends on if they have some other thing. What do you think, because this can affect your liver, we also would want to know or be cautious of? If they're on other medications that can affect their liver, what's something else that can affect your liver? If they're an alcoholic, this could be contraindicated, right? Because their liver is already affected. And so I know that this is going to affect their liver. And if I give this to them, it's going to increase that risk for hepatotoxicity. That's digoxin. Mm-hmm. Um, so we need to make sure we're checking their cholesterol levels in addition to their liver function. And then remember that muscle pain, I would say that's one of the biggest side effects of this. And if somebody reports that, you do need to be concerned, because I'm worried about what? Rhabdo, right? And so if I'm worried about that, what lab am I checking? CK, right? So CK is telling me muscle breakdown. So that could indicate that it could be rhabdo. If they have rhabdo, their kidneys are going to be affected, right? So then creatinine, BUN, that could be affected. But if I'm measuring specifically if they have rhabdo or just for that muscle pain, CK is what we're evaluating, okay? Um, if people are older, if they have a lower body weight, or if they have hypothyroidism, they have an increased risk for rhabdo. Um, I talked about what that is going to look like. There are a lot of interactions with different medications. And so, again, if you can't remember all these, if your patient is on a statin, maybe specifically look to see, are there any contraindications with the medications that they're prescribed. Specifically, if they've been on a statin for 10 years and now they're on a new med, of making sure that that's not going to be contraindicated. Some of those include some antibiotics, things used to treat HIV, and then other medications that can treat cholesterol, like fibrates or ezetimibe or Zetia. Um, so those are going to cause the level of the statin to increase. So they're increasing the risk for rhabdo and increasing the risk for liver to be impacted. Okay. What can I drink, Tina? I'm not having my grapefruit juice, okay? And so that is going to also increase the risk for toxicity or elevated levels of that. I would say the rule is to avoid it. And I would say, as the nurse, I'm going to tell you to ask your doctor before I say anything like that. Probably yes. But I'm not the one making that decision. He gets paid more money than me. So good luck with that. Um, and and again, I would say that this is one of those things. We'll talk about this a lot of like, it's more important probably that you're consistent versus avoiding or increasing, if that makes sense. So consistency, as long as these levels are being maintained, you're not having consequences. I have a note on page 841. It talks about the interference of grapefruit juice. All right, and then on page 841 and 842, it has your drug card and the nursing considerations. I've said all of these things. You can look at this if you want to, and I have a couple more little slides about this. Okay, so our cholesterol is synthesized at night, and these specific medications, simvastatin, lovastatin, and fluvastatin, those have a shorter half-life. And so in order for them to be more effective, I'm giving them when my cholesterol would be synthesized to stop it, further stop it, if that makes sense. Okay. So for those specific medications, it would be important for them to take it at night. Here is another just little drug card. We're not going to give them grapefruit juice. I'm giving this if their LDL is high, if their diet isn't controlling it, if they have CAD, or if they have a history that puts them at risk. If they have hepatitis, cirrhosis, alcoholism, or elevated liver function tests, I would hold these things. I'm monitoring cholesterol, triglycerides. I look for the LDL to go down. And then I know that muscle pain can be a side effect. I am concerned about that. We're checking that CK to make sure that they're not having rhabdo. And sometimes it just is so severe, even if they're not having rhabdo, that they'll try another medication because it can be very impactful. Once they stop taking the medicine, the muscle pain does go away. And let me see if there's anything else I wanted to tell you. Do not give these to pregnant people. All right. What could cause a drug-to-drug interaction with bile acid sequestrants? I said this quickly, so I don't know if y'all recall. Very good. So it binds to that, right? So that would be cause them not to work correctly. Okay. Next, we have cholesterol absorption inhibitors. So we're inhibiting the absorption of cholesterol in the small intestine. These can be used alone, or they can be given in conjunction with other medications and diet exercise modifications. The medication in this category is ezetimibe. Zetia is the other name for that. It can be used alone or in combination with statins, which just makes the LDL be lowered better. Or it can be given with fenofibrate if it is genetic causes. All right. There's going to be less cholesterol delivered to the liver, and then the liver is going to be able to get rid of it more, basically. I have a note that table 47.3 goes over the indications. I've already said what those are. Again, I do just want to say this isn't considered the first line. Okay, so this would be in conjunction with or as an alternative if they had complications. All right, this is contraindicated if they have an allergy to it previously. And we don't want to give this with statins if they're pregnant, lactating, or if they have severe liver disease, because it's going to increase the risk for liver toxicity. The side effects of these, or what we're worried about, are going to be similar as with statins. So we're looking for the muscle pain and we're looking for the hepatotoxicity. There also can be headaches, fatigue, GI issues. These, if they're given in conjunction with fenofibrate and the patient has gallbladder issues, there's an increased risk for the development of gallstones. So we need to make sure that we are closely monitoring that medication and know or closely monitoring for gallstones. They may even do scans, and then really consider changing and not giving those medications together. And so it isn't recommended to give Zetia with fenofibrate if that can be controlled. The bile acid sequestrants reduce the absorption, and so if they are using those concurrently, we need to separate them by like give it 2 hours before or give it 4 hours after we've taken the bile acid sequestrants, or otherwise they're not going to work the way that we're supposed to. We have the increased risk with fibrates and statins for impact on their liver and their muscles. And then with cyclosporin and warfarin, these medications can increase the concentration, which increases risk for toxicity and bleeding. So that would be an indication to try a different drug or reduce doses. Here is our drug card for that. So we can take this with or without food. Make sure you're considering what other drugs they're taking with this. Monitor their liver function, and that's going to be especially important, and the CK or for muscle pain if they're taking that with statins. Okay, these are the monoclonal antibodies. I'm not really getting into this a whole lot. I will just say that these are used to reduce the risk of MI, stroke, or cardiac events, basically, because of elevated cholesterol. They're used to lower LDL in patients who have genetic or acquired high cholesterol. The deal with these, really the biggest thing of why they're not used as often, because they work the same way that our endogenous antibodies work, is because they're very expensive. And so they're not used as often. They can be given sub-Q and usually over like 2 to 4 week time span. So they lower LDLs and allow the liver to process it more, and the consequence of that is lower LDLs in our blood. This not really getting into if they're allergic to it, we don't want to give it to them. They could have the risk for itching, vasculitis, same with the muscle aches. Unique to this, they can have like upper respiratory type infection looking things. So there aren't a lot of interactions with other drugs because this acts like our endogenous antibodies. So it can be preferred if people have other or reactions with other drugs or have to be on medications that interact with the other drugs. But again, it's very expensive, so not common for people to receive these. All right, some of the other drugs include fenofibrate, gemfibrozil, or fenofibric acid. All of these medications decrease triglyceride production and the transport, and they increase HDL. Okay. Just as a whole, side effects of these are gallstones, GI upset, hepatotoxicity, and muscle pain. As far as teaching considerations, people need to take these 30 minutes before breakfast and dinner, and need to make sure that they're monitoring their liver function. So a lot of times these are used in combination with diet and exercise. Trying to see if there's anything else I want to say about this. I feel like I highlighted something. The gemfibrozil, we either do not need to combine or monitor closely for the development of rhabdo. So reports of muscle pain would be extra important here. And then the fenofibric acid, there's an increased risk for bleeding with warfarin. So monitoring bleeding times is also going to be important. Other things, or another thing that can be used is niacin. So this is just vitamin B3, and we can give very high doses of these to treat high cholesterol. So it works by decreasing the synthesis of lipoproteins and triglyceride. The key side effect with this is flushing, but they may also report GI upset, pruritus, or muscle pain. So that is a recurrent theme through all of these medications of things that we would want to be aware of that could indicate that development of rhabdo. It also can impact uric acid, so there is a risk for gout. If these are combined with bile acid sequestrants, they work better. And then we can give this at night also in order to make them be more effective. If they are given in conjunction with bile acid sequestrants, the administration of that need to be separated by about 4 to 6 hours in order so that it can be absorbed. Other things that we can do, I'm not really getting into this. Omega-3s, they can decrease the synthesis of triglycerides. The biggest risk with that is that it can increase bleeding. So if someone's already on blood thinners or at risk for bleeding, or if they're having some sort of procedure, that would be important to know. I'm not going to talk about these, but you're free to read them if you want to. Um, the only thing that I will say about this is you see there are black box warnings for both of these that can be very significant. And because of that, I want to point that out of if you don't know a drug, if you had to give these and you've never heard of that, there's no way for you to know that if this is at risk for a tendon rupture, and I just go give this without knowing what this is for, then somebody complains that their ankle's hurting, I might say, oh no, that's terrible. And they could be developing a tendon rupture as a consequence of this medication. Okay, so knowing what those consequences are, knowing what those huge warnings are very important. And I don't know that if I don't look it up. All right. So the most effective is going to be combining these different therapies if they're not effective on their own. I do have a note here to just remember that the statins or those HMG-CoA reductase inhibitors are usually not combined with niacin or gemfibrozil. So because they target different aspects of the lipid metabolism, excretion, whatever, they are able to work more effectively because you're combining those things. If they are at an increased risk for rhabdo, I definitely don't want to combine things that can increase that risk. Make sure that they're using their lifestyle changes, exercise, diet, and then I've already said this. I did want to ask, an HMG CoA reductase inhibitor, is that an agonist or an antagonist? Why? I'm stopping it, right? So an agonist is going to make it work better, and an antagonist is stopping it. Very good. All right. The nurse is caring for a patient taking an HMG-CoA inhibitor. Which would be an appropriate intervention for this patient? B. I'm assessing pain. Why? That's right. Very good. All right, one down.